The first important finding from the work that we did on pharmacovigilance in Uganda was the discovery that the healthcare workers in Uganda are well able to recognize suspected adverse drug reactions and indeed to describe them competently. So the fact that the National Pharmacovigilance Centre receives rather few reports annually is not down to a failure on the part of the healthcare workers, rather it is a failure of reporting in to the National Pharmacovigilance Centre, and that is driven partly because the forms are not ideal and also because there is limited feedback from the National Pharmacovigilance Centre back to those who had contributed information. And these are problems that are soluble in the next steps. There was also another important finding, which was on the missed first day of antibiotic prescribing.
So, for instance, we found that, when we undertook a study on hospital patients who were taking antibiotics, and these patients were prescribed antibiotics, life-saving antibiotics, and we found that they missed all of their day one doses. Now that can be very serious for antibiotics, especially if someone has a very acute illness. So we think that that's one of the areas that can be addressed locally within the health facilities, and involvement of all the stakeholders, namely the nurses, the pharmacists, and the physicians, can, I guess, address that problem, especially if communication between them and with the patients improves.
In fact, it was about a third of the patients who had been prescribed antibiotics actually missed their first day's dosing. So the problem with antibiotic prescribing in the UK is they're prescribed inappropriately, whereas in Africa, in Uganda, the problem was appropriate prescribing, but a medication error in effect, whereby a third of the patients didn't receive their day one dose, and some of them stayed in hospital for a relatively short time, and if they were prescribed a 5-day course, they didn't get the full course because they were dismissed from hospital after about 3 days. So I suppose in the next steps, these are problems that we hope to address by doing an audit in those wards to see if improvements by involvement of the healthcare staff, as Ronald said, can reduce that medication error rate on day one. And all of the work so far has been in adult patients.
Yes.
And we need to study what's happening in children in the pediatric wards in Uganda to see if there are similar problems that need to be solved there.
And we hope that the issue of reporting could actually be improved if the mobile phone app, which was implemented in the UK last year, could be implemented in our setting where the use of mobile phones is actually prevalent, and the penetration rate is 20% every year. So that, we think, will improve the reporting. And not just the reporting, we want to establish a routine analysis platform for all these reports so that we can identify on an ongoing basis the problems of medication use in the community.
We're obviously very grateful to the Cambridge Africa programme, first of all for supporting Ronald's Thrive PhD studentship, and we hope to be making application for postdoctoral work to continue and the improvement of pharmacovigilance in Uganda.
For a long time, pharmacovigilance has been a neglected giant in my setting, and I hope, and I'm thinking that this work will help revive that giant and in the end improve not just the system per se, but the terminal end, which is improving the safety of medicines in our setting.